Hello, I'm David Rosensweet. I'm a medical doctor. I've been specializing in treating women in menopause for the last 32 years. And I want to talk about an article that just appeared in the British Medical Journal, the title of which is Menopause Misinformation is Harming Care. Symptoms should be prioritized ahead of testing, end quote. And I want to give you some of the sound bites from this article and then give you my response to it. One of them is that many women who access this type of testing, and I'm quoting from this journal article, are unaware of the limited supporting evidence and are influenced by trust in their healthcare provider. In reality, these tests are of limited clinical use because there is no clearly defined therapeutic window for menopause hormone therapy, and some testing techniques do not offer accurate or precise assessment of hormone level. The principle of evidence-based practice is that a test should only be done if the result will directly guide patient care. For menopause and perimenopause, hormone testing offers no reliable way to determine who will benefit from treatment. And there's a few more sound bites in here, as well as a full editorial. And I'd like to give you my response to this. And I've actually submitted this to the British Medical Journal in hopes that they will publish it as well, because they have an avenue for response. Dear editor, we respectfully challenge the recent editorial's conclusion that menopause hormone therapy should be guided solely by symptom alleviation and that laboratory testing is unwarranted. Symptom-guided dosing is insufficient. In a study of 54 women in my practice who reported satisfactory symptom relief on MHT, 49% had estrone plus estradiol, potent estrogens. They had levels below thresholds associated with protection against bone loss and vaginal atrophy, while 25% exceeded levels linked with breast glandular cell proliferation. Thus, 74% of apparently well-treated patients were outside safe and effective ranges when assessed by physiology-based standards. Symptom relief alone does not reliably indicate adequacy of treatment. Here's the limitations of current testing. Spot serum testing assays are undermined by pharmacokinetic variability, and salivary testing correlates poorly with clinical states. And I do agree that urine spot testing is not valid scientifically. By contrast, 24-hour urine hormone testing, first applied in breast cancer research since the 1960s, provides a stable, integrated measure of exposure that correlates more closely than with physiologic effects. Regarding establishing reference ranges, in 2009, we undertook a study, as evidenced in footnotes 3A and 3B, supported by reference laboratory using LCMS/GCMS technology to define physiologic ranges in a rigorously selected healthy young women with an N of 24 with confirmed ovulation with pregnenolone levels greater than 1,500. From these data, the one standard deviation range for potent estrogens, again the sum of estrone and estradiol, was 10.1 to 33.4 micrograms per 24 hours. Using the medical literature and split specimens comparisons, we identified a safety window for MHT of 5.9 to 10.1 micrograms per 24 hours. This was sufficient to prevent bone loss and urogenital atrophy while avoiding levels associated with breast proliferation risk. These findings highlight that testing is not a substitute for symptoms, but a necessary complement. Without objective confirmation, women are at risk for undertreatment, failing to achieve skeletal and urogenital protection, or overtreatment with excess breast stimulation. We therefore urge reconsideration of the editorial's position. Symptom relief, while essential, cannot stand alone as the determinant of optimal MHT dosing. Physiologically anchored 24-hour urine hormone testing offers an evidence-based tool to refine treatment and improve safety for women in menopause. And then I list a series of references, and should this appear as a response in the British Medical Journal, you'll be able to see the full publication of this. Best wishes to you all. 24-hour urine hormone testing is a very important adjunct to excellent menopausal treatment.